Welcome to This Medical Life podcast. These are the stories of medicine with Steve Davis and Dr. Travis Brown. This is the story of thyroid lumps, part 1. Dr. Travis Brown, we're talking thyroid lumps. Am I right in assuming this is taking place around the neck area?
It is. This is thyroid lumps. This is a pretty specialised area. And from the history of it, it's actually a recent understanding. And the reason why I say that is the thyroid got its name from Thomas Wharton. And he called it that in 1656, as from the Greek word meaning shield. And the reason he gave it this name is because they thought it had sort of a protective kind of, shield, a sort of, it was an appearance. If you've ever seen an anatomy of it, it looks like it's a little sort of shield down the bottom of the neck. In fact, Leonardo da Vinci did some beautiful drawings of it. Now, he thought it was actually it was a filler of a gap for neck muscles, as well as to stop the trachea actually hitting the sternum.
So he thought God was using it as polyfiller.
And so that's why I suspect that's probably why they called it the name shield. But even Galen thought it was a buffer between the heart and the brain. So it's the reason why it's recent is because our understanding of this is recent, and even our terminology that we use, the history is inherently linked to goiter. Now, you're familiar with the term goiter?
I am. I remember seeing those images in Wikipedia and medical encyclopedias we had growing up, those large growths.
Right, and that actually, the name goiter is Latin. It comes from goituria, which means throat. But over time, it became to be known as neck swelling. And so this is, why goiters develop. Well, the goiters develop, what we know is the thyroid needs iodine to produce all of its effectively metabolic free T4, free T3 that helps pretty much run our body. And it has the metabolism sort of center. And so it needs iodine to produce them. If it doesn't have them over a long period, the thyroid starts to swell. The theory is that it's trying to pick up all the iodine that it can. It gets larger and larger, and as the deficiency continues, it just swells up. And so you have patients who have, you can have a symptomatic patient, but you can also have symptomatic populations, and you can actually get areas where it's endemic. People have goiters because everyone is deficient in iodine.
Right.
And this is where we have iodine, which is actually in seaweed, it's in fish, it's in eggs, it can be in dairy products. So you can imagine where...
Yes, not many in Japan.
So, and the areas where you would actually think that would be is probably in history, in sort of inland kind of places where they just don't have access to it. And so this is also where you start to see the medical word called cretinism, where that was congenital iodine deficiency. And you get these short-statured children that have stumpy sort of legs and hands and feet, large neck swelling, and they have intellectual impairment. And this is because of congenital iodine deficiency. It's from thyroid. They needed iodine for development. And goiters were well known in the ancient world. We actually have the first sort of recognized area is 2700 BCE, and this is the Yellow Emperor Hung Ti. He wrote about it in a text called the Yellow Emperor's Classic of Medicine. Now, this is 18 volumes, 162 chapters, and notes that seaweed is a treatment for goiter. Indian doctors, they actually were really well versed in thyroid, and they had something like 3 different conditions about thyroid conditions. One was Vataja, Kaphaja, and Madaja, and this is hypothyroidism, hypothyroidism, and thyroid cysts. And this is ancient text. And so again, you look at all the different cultures and races, and they all had different ideas. And so even we get to Hippocrates and Gaius, they thought a goiter was caused by drinking snow water.
Snow water? What What would be their theory behind that?
I don't know, but it's an interesting one. They thought that that's how it developed. But again, Greek, you wouldn't probably come across it too much in the Greek diet as well. So that's how they probably, deduction, that's who they thought. So it might have been high up in the mountains maybe. And so it's not until we get into the 19th and 20th century that our understanding and physiology of the thyroid and its function become important. In fact, iodine was isolated in 1811 by a French chemist named Bernard Curtis. And he was manufacturing saltpeter, which is potassium nitrate, a component of gunpowder.
Yes.
He was washing seaweed ash with sulfuric acid and saw these violet fumes. And when the violet fumes went on a cold surface, it produced purple crystals. And these purple crystals they called iodine. And that's because it means in Greek, violet coloured. And so the hard thing, and now we're talking about thyroid lumps. Why am I talking about goitres? Because historically it's impossible to actually separate goitres from thyroid cancer. And the reason is because they didn't know thyroid cancer existed. It was always neck lumps, and goitres would have been far more prevalent from iodine deficiency than thyroid cancer. And so we actually have the first documented case. So it's written in an article called Evidence of the Earliest Thyroid Cancer Operation Performed Successfully. Now, this is about an 18th century German surgeon called Christian Ludwig Mersiner, and the author describes the following.
He described a very interesting case that he came upon in 1787. A doctor noticed an unpainful growth on the front part of the neck of a patient that increased from month to month. Soon it started producing pain and difficulty in breathing, and Mersiner was summoned to excise the growth. Upon examination, he found a growth of the size of a clenched fist, and he performed the operation. Bleeding was profuse, but numerous doctors were present and jumped in and squeezed the many wounds in the arteries with their fingers, and I calmly eliminated the whole tumour. The wound healed well, and the patient had no pain or fever. However, 3 months after the operation, the patient died suddenly, appearing to suffocate, and Mersiner asked for a post-mortem examination to learn why. The operated site was clean, but numerous growths were found between the pharynx and the trachea and in the esophagus, while the lungs were full of hard lumps firmly attached.
So this is most likely the first described thyroid cancer that we've come across. Now, again, we're discussing thyroid lumps and investigations. The investigation that is thoroughly modern is what we call the fine needle aspirate. Now, fine needle aspirate is we put a needle into the lump, take out some of the fluid, if it's a fluid filled, and look at the cells under a microscope, and we can actually diagnose. It's an incredibly powerful tool, and you look at the cells, and a pathologist can look at it and say they are benign or malignant. There's a few grey zones, which we will discuss, but this was first described in 1930 by Martin and Ellis. Now, they used an 18-gauge needle to this is the diagnostic tool. Now, there's nothing small about an 18-gauge needle. This is a large needle, and it didn't take off until about the 1960s when they used a much smaller needle from the Scandinavian study, and then it started to actually take off. That this was a good investigation, relatively simple. I would say it's probably a little bit nerve-wracking aiming for someone's needle at someone's neck, but we have amazing clinicians and proceduralists who are able to do this. And look, it is a common test. It is a common investigation. The results can be very useful, sometimes can be a little bit confusing. And so this is why we're wanting to go and understand a lot more about thyroid carcinoma, thyroid lumps, and there's even molecular these days. So we're actually getting quite a lot of understanding happening, and this is why we're doing this episode.
Dr. Tiffany Symes is a histopathologist and Deputy Director of Anatomical Pathology at Melbourne Pathology. Dr. Symes trained at the Austin Hospital, Mercy Hospital for Women, Royal Women's and Children's Hospitals and St John of God Pathology. She completed her training in anatomical pathology in 2011. And Tiffany's our guest on this Medical Life podcast. Tiffany, welcome.
Thank you very much. Nice to be here.
Tiffany, let's get underway with the basic question, and that is, how common are thyroid lumps?
They're actually very common. The College of Pathologists quote that if you were to palpate your thyroid, about 5% of people would find a thyroid lump. If you actually use ultrasound to investigate, you'd find that actually up to 50 to 60% of people actually have thyroid lumps. So extremely common, but the good news is that most of them are benign. So only about 5% or so of those lumps will turn out to be anything to worry about.
Now, we've mentioned fine needle aspirate just in the introduction. When is fine needle aspirate required?
Yeah, so look, it's an interesting point. Any palpable nodule has the potential to need an FNA, but usually what we do is use radiology features. So there'll be some clinical features, the size of the lump, maybe the texture of the lump that might be concerning. But we generally use radiology features to determine whether or not we would proceed to fine needle aspiration. So the radiologists have a system that they report on that categorise the lesion into one of 5 categories. It's called the TIRADS system, TIRADS. Stands for Thyroid Imaging Reporting and Data System. Sounds very formal. It's a 5-tiered system. They'll categorise those lesions into one of those 5 tiers, and as you go up the tiers, your risk of malignancy increases. So a tier 3, 4 or 5 lesion would generally then score an FNA. So once we put that clinical data together with the radiology data, then there's usually a recommendation for whether or not an FNA would be required.
So who's doing FNAs these days?
It varies. The vast majority are actually done by radiologists under ultrasound guidance, and generally that would be accepted as best practice, partly because they can actually visualise the needle passing into the nodule. They can be sure they're in the right place when they sample the specimen. And also, if lesions are small, it's often very difficult if you don't have some kind of radiologic guidance. The quoted figures are sort of 60 to 70% aspirations done by radiologists. You might find a smaller number by clinicians, surgeons or GPs who might be able to palpate a large nodule, might do their own FNA in their rooms, maybe 20% or so, and then a much smaller percentage of pathologists will actually do them. We used to do them more often as pathologists. We used to run clinics and do FNAs. But today it's moved more towards radiologic guidance with ultrasound.
Now, looking at the cytology, so this is clearly when you actually receive the slide that's been sent to us and processed. There is something called the Bethesda system for reporting. What is that?
It's a scale similar to that radiology scale I briefly described earlier. It's a risk of malignancy scale, basically, and determines a probability of cancer based on the analysis of the cells in the FNA specimen. So we do the cytology assessment. Again, we assign a category. This one has 6 categories in it, and each of those categories represent a percentage risk for cancer based on what we've seen. In Australia, we actually use the modified Bethesda system for reporting thyroid cytology. Not only does that include the diagnostic categories ranging from benign to malignant, and the percentage risk of malignancy, but it also incorporates a recommendation for management, so what to do next when you get that category back. So it's a system that is valuable for both cytology reporters, so that we have a standardised system for reporting them and everyone understands what we mean when we report it, but also aids the clinician in what they should do with the result once they get it.
Now, that even comes into a bit of a grey zone. So does that have grey zone categories? Which ones are those?
Absolutely, yes. So the second category, the first category is non-diagnostic. That's sort of not really a grey zone. I mean, that means we need to probably repeat the FNA, but there are grey zone categories within that, yes. So some cases are clearly benign, some are malignant, and then others we would determine as being of varying risk for malignancy.
Yeah. Now, we're looking at during my training about however many years ago, it was not that long, but it's starting to get to the point where you're doing even molecular testing. Do you do that on cytology specimens?
Yes, we do now. So it used to be to have molecular testing, you had to send it overseas, but we now thankfully actually have molecular options here in Australia, and they're being used relatively frequently now. So molecular testing would normally be performed on those, we talked about the grey zone, those kind of uncertain ones, and even sometimes ones that are considered malignant, to aid with determining whether or not they've got a higher risk than what we thought they had. So it's a way of providing a more definitive answer, I suppose, whether or not surgery is required or whether or not they can be clinically monitored. The two that people probably will be familiar with the names of are ThyroSec and Afirma. Okay, so they're both similar sort of panels. They're next generation sequencing technology. They look at 100 or more genes, and then according to that genetic profile, they'll determine whether or not the lesion is considered to be a higher risk for malignancy or a lower risk for malignancy. The thing I suppose that should be noted is that they're not covered by Medicare, so they do have an out-of-pocket cost for the patient. But a lot of people would say that should also be considered in the context of what it would cost to have a lifetime of thyroxine replacement if you had your thyroid removed for a benign lesion. So it's weighing up those two things with regards to costs. It's used fairly regularly now for cytology specimens.
Is that a result that you get as the pathologist and you incorporate into your report, or would this be sent directly to the surgeon and they actually have to sort of work it out?
So it's probably a bit of both. Usually the surgeon would be, the pathologist will in combination with the surgeon and discussions, etc., will recommend it. It will get sent, and usually both clinicians would receive a report, but we would also want to integrate that report into our cytology report. We try and integrate those things as best we can.
So there's a bit of an inordinate amount of time spent on a question that I want to ask about, and I'm sure everyone's gotten it. I'm sure pathologists don't like actually reporting it, but it's this category of atypia of undetermined significance. And the reason is because doctors know what to do with benign, they know what to do with malignant. The path ahead's very easy. What do you do with atypia of undetermined significance?
Yeah, look, and we don't like reporting it. And in fact, we try and keep it under 10%. I mean, that's what the college recommendation is, that we only assign that category when we really have to. So we try not to use it if we don't need to, for the very reasons that you've just explained. That category is a category where the cell morphology in the specimen is not convincingly benign, but the degree of atypia, and that might be just cytologic atypia or it might be architectural atypia, is not sufficient for a diagnosis of either follicular neoplasm or malignancy. So it's where the quality of abnormality is just not enough to get there for those other categories. And it's tricky, and it is a little bit subjective. It's one of those categories that I can assure you, if you're wanting to call a Bethesda Category 3, you show it to your colleagues, you get opinions, you make sure everybody's in agreement before you put that one out, because we do know that it can be frustrating for people. But there are just some times where we just can't be sure. I suppose the thing that should be reassuring for clinicians, although they might be frustrated by it, is that category does infer a low risk of malignancy. So even if we do assign that category, it's unlikely that would be a malignant lesion. And usually a repeat FNA in a few weeks, 6 to 8 weeks' time, is what is recommended. That will often then clear up the problem.
So when you would do cytology, taking out some fluid and just looking at the cells, so for our listeners, just looking at the cells is cytology. When we do a cell block, we actually spin it down, put it into paraffin, just like it's a histology specimen. Do you do that in thyroid?
We do cytology. We do cell blocks in any specimens where we think we might need to do additional studies in particular. So yes, usually the clinician, the radiologist, will do needle washings. So they prepare the FNA specimen, they wash the needle out into saline, we will then prep that into a cell block if we've got sufficient material. If there's any concern about the diagnosis, if we particularly want to do immunohistochemistry or some other type of staining on those, then we would use that cell block material for that. So just like any other cytology specimen, cell blocks can be used, yep.
There is a category of follicular neoplasm. Why does it have its own category?
It's important because of the diagnosis of follicular carcinoma being dependent on histologic features alone. So when we get a cytology specimen with follicular features, which is that it's forming follicles, we can't tell whether that's benign or malignant on cytology preparation. So by definition, a follicular carcinoma must show invasion, and we can't see that with cytology because all we see is cell features. We don't actually see the architecture of the gland. We don't see the quality of the lesion. So a benign nodule will potentially look the same on cytology as a malignant one with follicular lesions.
Do we actually recommend in the report what should happen with this patient?
Yes, we provide those recommendations according to the modified Bethesda system. So usually recommendations are part of the report.
We are about to pause and then regroup to come at a different angle of this discussion with you. But before we do that, Tiffany, any final thoughts or advice for doctors about thyroid cytology itself?
FNA is a very reliable and cost-effective diagnostic modality, particularly for the sort of preoperative assessment of thyroid nodules. We don't want to remove thyroids if we don't need to. But the thing that I think is important to bear in mind is that the key to success really requires a very good quality sample. So, it's our aim to minimise non-diagnostic rates, and really that non-diagnostic rate is dependent on having a very good sampler and that the specimen is sent in a good condition. So I suppose my recommendation is make sure you've got a good qualified and experienced radiologist that you refer to for these assessments because it will result in more definitive outcomes.
My wife works in software and they talk about garbage in, garbage out. If you don't have that good initial data, you're not going to get many great results. That's what you're saying in nicer terms.
Yes, I suppose so. It does make a difference. If the quality of the material that we're getting is good, then we're more likely to be able to give a definitive result. Yeah.
Dr. Tiffany Symes will resume in just a little while on This Medical Life.
Thank you.
Associate Professor James Lee is a leading endocrine surgeon in Australia. He is a co-editor of the Endocrine Surgery Section of the ANZ Journal of Surgery and a deputy co-chair of the Endocrine Surgery Section of the Royal Australasian College of Surgeons. He qualified as a general surgeon in 2010 and underwent further training in endocrine surgery at the Austin Hospital in Melbourne and the Royal North Shore Hospital in Sydney, where he undertook the prestigious T.S. Reeve International Fellowship. His practice is at Epworth Healthcare and Knox Hospital and also has public appointments at the Alfred Hospital and Monash Health. Associate Professor Lee completed his PhD thesis on biomarkers of thyroid cancer. He's published over 70 peer-reviewed publications and contributed 3 book chapters to date. Associate Professor James Lee is a leader in thyroid cancer research and our guest on This Medical Life podcast. James, welcome.
Thank you, Stephen, and thank you, Travis, for the invitation. That's a very kind introduction. It is my absolute pleasure to be here speaking to you both, as well as your listeners.
When should a patient be referred to an endocrine surgeon about a thyroid lump?
So thyroid lumps generally present in one or two ways. Either the patient has noticed some symptoms themselves, or they can be incidentally detected on imaging techniques such as ultrasound or CT scan. For example, a patient might be having an ultrasound for a carotid artery, which is right next to the thyroid, and the thyroid lump can be seen or found incidentally. Or in my practice at the Alfred Hospital, which is a trauma hospital, we scan patients coming with major traumas, and we often find on the CT scan that there's something in the thyroid. And with any thyroid lump, whether they're causing any symptoms to the patient or whether they've been incidentally detected. They should all be carefully assessed. And I guess the short answer to the question is, if the clinician looking after the patient who had initially detected these lumps, if they're not sure or they're not confident in how to assess these lumps, then the patient should be referred to the surgeon for further assessment.
Now, a lot of these patients will have had cytology results before. Now, how useful are the cytology results in determining what you're going to do?
Well, while cytology isn't the only result we use to base our subsequent management decisions on, it is extremely important. So we look at three main things, cytology being one of them, but also our clinical findings by taking a history and examining the patient, as well as ultrasound or plus minus other imaging results. And together, using these three modalities, we make subsequent decisions. In 2020, we published a paper in the European Journal of Surgical Oncology regarding how useful cytology is in subsequent surgical decision-making. We actually found that in patients who have a definitive cytology, meaning a cytology that can confirm or exclude cancer, for those patients, 96% of them have the optimal initial surgery. So they needed one surgery and it was exactly the surgery they needed. But for patients with an indeterminate cytology, so these include Bethesda categories 1, 3, 4, and 5, where cancer is possible but can't be conclusively confirmed or excluded, only 41% of them ended up with the optimal surgery in the first round. So they either had surgery just for diagnosis without any symptoms, so if we had known it wasn't cancer, they could have avoided it altogether, or they needed further surgery to complete their entire surgical treatment. So it's very important.
Yeah, I was going to say that 41%, that's pretty low. Was there any recommendations that you had about trying to, how do you approach that around the 60% for better treatment?
Yeah, well, in some way, I think we're being quite harsh on ourselves because we have very strict criteria. So the vast majority of those other 60% who we deem not to have had optimal surgery initially, they may have had a reasonably large lump they would have wanted out anyway, but because they were asymptomatic and it wasn't cancer, we sort of categorize them in those that could have avoided surgery. Yeah. So the recommendation was to further find other adjuncts to help with the cytological or preoperative diagnosis or exclusion of cancer.
So is there any role in for thyroid function blood tests in patients?
There's some confusion with the blood test or thyroid function test for in the diagnosis of thyroid cancer or thyroid lumps. While the test doesn't help exclude or confirm cancer, it is essential. In fact, any patient with any thyroid pathology being assessed needs to have thyroid function test. So in the context of a thyroid lump, it can help us decide what further investigation is required. For example, if someone has a low TSH suggesting they are thyroid toxic, I would add a nuclear medicine scan to the investigations. And thyroid function also help decide the extent of surgery. For example, if someone's thyroid is already either overactive or underactive, we have a lower threshold of recommending a total thyroidectomy rather than a hemithyroidectomy, because the other half would either still be overactive and they still need to be treated for that, or the other half may not be providing enough thyroxine post-surgery. So they're going to be on medication anyway. So yeah, it does help us make further decisions, even though it doesn't help decide whether something is malignant or not.
Do you consider testing calcitonin in patients with a thyroid lump?
Yeah, that's another very interesting question that led us to publish a paper a couple of years ago in the ANZ Journal of Surgery. So there are different practices throughout the world. In European countries, calcitonin is a routine blood test in anyone presenting with a thyroid lump, whereas in Australia, it is used more selectively. So calcitonin, I guess going a step back, calcitonin is used as an adjunctive blood test or biomarker for medullary thyroid cancer, a specific type of thyroid cancer, which is quite rare. And malignant thyroid cancer, medullary thyroid cancer is only diagnosed cytologically in about 55 to 65%, and which again, harking back to our previous conversation regarding having a definitive diagnosis preoperatively really helps us make surgical decisions. We found that if patients with indeterminate cytology, a calcitonin is added, we can increase our ability to further diagnose another 14% of these patients who ended up having medullary thyroid cancer, and therefore having the optimal extent of surgery initially. So it is useful in certain circumstances.
As we expect, there's lots of nuance in all those different tests and how you use them, etc. So let's then turn to imaging. What imaging is useful or important for a thyroid lump?
There are several imaging modalities that may be useful, but by far the most useful imaging modality is an ultrasound. So because the thyroid, I know, you can see the surprise on your faces. Because the thyroid is a relatively superficial, so it's very close to the skin. It's just under the skin in the neck. Ultrasound provides really good quality images for it. It's able to give us its relative size. Its size relative to the thyroid gland itself. It's able to give us details within the thyroid itself, and there are certain features on ultrasound that would then subsequently guide us to the need for an FNA biopsy. So in addition to ultrasound, in some patients, I would also organize a CT scan, especially for those with a retrosternal goiter, where the thyroid is so big that it's extending into the upper part of the chest behind the sternum. And because of the presence of the sternum, ultrasound beams aren't able to see it clearly, and therefore a CT scan is very useful. And as mentioned before, if someone has a low TSH level suggesting thyrotoxic state, a nuclear medicine scan is also very useful to help us determine where is that thyrotoxicity coming from, whether it's from the nodule or the rest of the thyroid or both.
We hear a lot about hot and cold nodules. Can you tell us the difference or how that's determined?
So hot and cold nodules refer to the appearance or the uptake of the radioactive iodine on nuclear medicine scan. So a hot nodule takes up more of the iodine. So just to mention this, thyroid gland and also thyroid nodules, some thyroid nodules is the only organ in the body that takes up iodine. So when the iodine is labeled with a radioactive or a nuclear medicine substrate, it can then be imaged through that. So a hot nodule suggests that the nodule is functioning autonomously. It has escaped the usual negative feedback loop through the thyroid stimulating hormone, and it's just producing too much thyroid hormone on its own. And a cold nodule suggests less or no uptake of radioactive iodine. And a cold nodule could be a completely benign cyst, or it could be a malignant lesion. So there's a common misconception that cold nodules are malignant. I think that is not entirely correct. Cold nodules are more likely to be malignant than hot nodules, but hot nodules can also be malignant. So like every other test, it is just part of, it's just one piece of the puzzle. We can't use it to sort of confirm or exclude malignancy on its own.
What are the determining factors for a patient to have an operation?
We can think of this question in sort of broad categories. Obviously, those with a malignancy or clinically significant cancer or clinically confirmed or suspected malignancy of a reasonable size. Those with symptoms either compressing in the neck, either affecting the breathing, affecting the swallowing, or affecting the voice, or just the sensation of pressure. So those that are locally symptomatic, or those with systemic symptoms of thyroid dysfunction, either usually overactive for patients undergoing surgery, but occasionally for patients with underactive thyroid as well.
Looking at the decision to take the whole thyroid or hemithyroid, is there an easy way to determine who has that and who doesn't?
I think that's quite, although it sounds like it's just decision of one or the other, there are so many aspects that we take into consideration, but I'll try and summarize it. So for patients that I would recommend a hemithyroidectomy, could be classified as those that with benign pathology that are limited to one side of the thyroid. So for example, there's a single nodule and the other side of the thyroid is normal and the thyroid function is normal. Or sometimes you can get a multinodular goiter that happens to only affect one lobe of the thyroid, so we can just remove that side. For patients with low risk and differentiated thyroid cancers, less than 4 centimeters without lymph node or distant metastasis, they can often also be treated with just a hemithyroidectomy. And in sort of rarer situations where someone who lives in an area who does not have ready reliable access to thyroxine, so you wouldn't want to remove the whole thyroid, or someone so for someone who isn't reliable with ongoing follow-up of the other lobe, then the total thyroidectomy will be more likely to be recommended. So for total thyroidectomy for larger cancers greater than 4 centimeters, cancers that will require further treatment with radioactive iodine, patients with multinodular goiter or toxic multinodular goiter or Graves' disease, all these would be recommended a total thyroidectomy. And the key thing here is that we discuss in some situations where a total or a hemi would both be appropriate, we then need to discuss these thought process with the patient and get their view on that as well.
Are there any important risks you discuss with patients about surgery on neck and thyroid?
Oh, absolutely. So the three main key risks associated with thyroid surgery are injury to the recurrent laryngeal nerve, which a unilateral injury can affect the voice, and the vast majority of these do recover spontaneously, but it will affect the patient's ability to work or for their daily function for a period of time, and less than 1% of these are actually a permanent effect. And the second key risk I discussed is the injury to the parathyroid gland. So there are 4 parathyroid glands. So this is not an issue if we're only operating on one side of the thyroid for hemithyroidectomy, but for total thyroidectomy or completion thyroidectomy, the risk of hypoparathyroidism is also around 1% permanent and about 3 to 4% temporary. And lastly, post-op hemorrhage. So obviously there's not a lot of space in the neck. So if there's any bleeding after surgery, it can become quite an urgent return to the operating room to remove the blood and the clot. So these are the 3 main risks. But the other thing I also always mention and to remind the patients, if they weren't aware, is that they will, if they had a total thyroidectomy, if they don't have any thyroid left, they are committed to taking thyroxine or thyroid hormone replacement for life. This might not sound like a big deal for someone who's already on other medication, cholesterol medications, blood pressure medications, but a lot of my patients are young patients. They're not on any regular medication. So that mental barrier to go from no medication to one regular medication every single day for the rest of their life, I think that's a big barrier. So that needs to be discussed, and they need to understand that.
What are some of the common diagnoses you get for thyroid masses?
So these can be broadly classified into benign and malignant. Benign diagnoses commonly are hyperplastic nodules, benign adenomas, or colloid nodules, and sometimes a thyroid cyst. And malignant ones, the most common is papillary thyroid cancer, and the second most common is follicular thyroid cancer, and the rarer ones are the medullary thyroid cancer we've mentioned before, oncocytic carcinomas, or the polydifferentiated or even anaplastic thyroid cancers. And there's a new entity known as NIFT-P, the non-invasive follicular thyroid neoplasm with papillary-like nuclear features. I could not quite understand how NIFT-P comes from that mouthful, but that used to be considered malignant, and now it's more towards the benign spectrum. So those are the more common thyroid masses that are diagnosed.
Now, in your introduction, and this is an emerging area in pathology,
Yes.
is molecular tests and markers. And this can be confusing for doctors who have trained, who have never come across this before. What are some of the important molecular tests and markers that are being used in either diagnosis or even management for thyroid?
Apart from the molecular markers that are done for pathology or histology confirmation, in clinical practice, we do not routinely use molecular markers, but there are some situations where it is potentially helpful. They're mainly in they're either in the diagnostic area or in the management of patients with aggressive and advanced thyroid cancer, where the standard treatment isn't really cutting it anymore. So for the diagnosis, so as we mentioned, 20 to 30% of thyroid FNA cytology is indeterminate. So in the US and gradually in Australia as well, we're getting access to molecular markers that can help increase our ability to make a preoperative diagnosis. And we have just finished a study supported by the Aftershock Foundation, using a local cohort of patients, using a panel of molecular markers. And we found that BRAF mutation found on FNA cytology, as well as other less common mutations, can help us increase our ability to make a definitive diagnosis preoperatively. And for patients with aggressive or advanced disease, there are some actionable biomarkers that can be treated with newer class of tyrosine kinase inhibitors, which we won't go into the details of now, but just for people to know that these treatments are available in specialist centers.
What kind of follow-up do you have for patients that you operate on?
We follow up on all of our patients that we operate on, and it depends a bit on the eventual pathology. For patients with benign pathology, we generally follow them up until full recovery, until they are happy with the way the healing process has gone, and also ensure that they are, if they need thyroxine replacement or supplement, they are on the correct dose for that. And for patients with malignant pathology, they generally need to be followed up long term, and that is usually done in conjunction with their treating endocrinologist, and also through a multidisciplinary team setting through the hospitals.
There is the American Thyroid Association risk stratification system to estimate risk of persistent or recurrent disease. Is that something we use here in Australia? Is that useful?
Yeah, that is probably the most commonly used risk stratification system in Australia. The unique thing about this American Thyroid Association ATA risk stratification system is that it is a dynamic system. So the patient will be given a risk category of low, intermediate, or high at initial diagnosis. And then that risk classification can then change each time they are followed up. So depending on their response to therapy, depending on subsequent imaging and blood tests or clinical findings, their risk can be recategorized from a lower risk to intermediate risk, or vice versa. They can go from intermediate risk or low risk if the response to subsequent radioactive iodine ablation progresses in the right direction. So that's the uniqueness of this particular approach. And the reason for that is we aim to treat each patient with a personalized treatment plan. So gone are the days where all thyroid cancer patients get these treatment, or just very broadly categorizing them into 2 or 3 categories. Now each patient is discussed in the MDT, the team meeting, individually, and personalized treatment plans are agreed upon as a consensus from the team.
What a comprehensive journey this has been. Thank you, James. Just finally, is there any advice or final thoughts you've got for doctors or even patients?
Yeah, thank you for that. Look, I think my final thought would be for both the patients and the clinicians, don't be afraid to talk to each other. I think communication is very important in this setting. And as I mentioned just before, we aim to provide personalized treatment for each patient. So it's very important for me as a clinician to understand the patient's value system, because in a lot of thyroid surgery, even in low-risk cancers, where there's not necessarily one only way to proceed. So there are several different options, and it's very important that together with the patient, we choose the right option for that particular patient, and the right option for one patient may not be the one for another patient. So I think communication is the key in this situation.
Associate Professor James Lee, thank you for being part of This Medical Life podcast.
Thank you for having me.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts on social media. Dr. Travis Brown can be found on X. His username is @Dr. Travis Brown. That's Dr. Travis Brown. And Steve Davis can be found on LinkedIn. Go to linkedin.com/in/TheRealSteveDavis. This has been a PathNotes Proprietary Limited production.